Hello students, I'm the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your favorite subject, most scoring subject. Now this is a very important video because in this I'm going to discuss the new pattern MCQs for the upcoming NEET PG. Now what is this new pattern? Stay right till the very end. We are going to discuss match the column kind of questions, multiple correct, arrange in correct sequence. All these questions are expected in the upcoming NEET PG. Feel free to get in touch with me on phone and WhatsApp on this number for your timetable and guidance, and thrilled to announce live career changing moment for all of you. Just enroll in this OGRR course. It's MCQ based RR. Whichever source OBGY you have studied from, don't worry. It's going to be PYQs, clinical cases, virgin MCQs, IBQs with beautiful handwritten notes. Of course, my timetable guidance, and you can revise the entire OBGY in just 2 days. And it's only 699 rupees. 20 to 22 MCQs come in OBGY every year. It's a single most important subject. More about this later on. So let us directly begin. And the first MCQ. Chalo. Now match the column. So when students get match the column, they get confused. Why this is very important? Because with this one MCQ, they're asking you 4 MCQs. So see how you approach the match the column kind of a question. Now when you look at the options, first start citing this, here are various conditions which they have told you, and here is the different management what we will do. Now for preterm labor, we know for preterm labor what are the 2 main drugs. So for preterm labor, anything whenever we have got preterm, what are the 2 main thing? Yes sir, one is the steroids. Why do we give steroids? So steroids are for prevention of RDS, that everybody knows, but also for decreasing the risk of intraventricular hemorrhage. And other very important drug is tocolytic agents. What are tocolytics? There are uterine relaxants. So here directly student think dexamethasone and preterm labor B1. Wrong. Clean bold. Fail. Why? Because sir, dexamethasone yes, but misoprostol is wrong, because misoprostol will cause further contraction, isn't it? We'll discuss misoprostol. So misoprostol is going to cause contractions. In fact, it is used for induction of labor. So I don't want misoprostol. I want a relaxant. So preterm labor is betamethasone and atosiban. What is atosiban? Please comment in the chat box. Yes, atosiban is a tocolytic agent. Atosiban is a uterine relaxant. Okay, it is a oxytocin antagonist. It is a oxytocin antagonist. Surely the question coming in the exam. So atosiban is one of the tocolytic. So B2. So directly if you see B2, so one option is ruled out. Is it clear to all of you? B2 correct. Now, whenever you have eclampsia, what are we going to do? Sir, for eclampsia, remember that immediately, whenever we have eclampsia, immediately, of course, we will give magnesium sulfate. Magnesium sulfate will be given to stop the convulsion, prevent further convulsion. Of course, antihypertensive will also be given. But can anybody tell me what is the definitive treatment? Yes, sir. Please understand this. If they ask you what is the definitive treatment, wait and watch, do time pass, never. If you do time pass, you have to go to jail. Jail mein dalenge. Okay. So the definitive treatment is delivery. Why? And this is very important, whatever may be the weeks between mother and baby, mother is more important. Okay, so let the eclampsia be at 28 weeks, 26 weeks, sir. If you cannot save the baby, it is okay. So when you have got eclampsia, again those who mark C3, wrong, jail. Magnesium sulfate, yes, but then deliver at 34 weeks. Here they have given eclampsia at 32. Will I wait for 2 weeks? No, we'll have to go to jail. Why jail? I'll put you in jail. Jail matlab ke it is a crime. Why? Because if you wait, mother dead, baby dead, you will be hanged to murder for double murder. Okay, you will be hanged to death for double murder. So, कहने का मतलब, what is the meaning is that, sir, whenever it is eclampsia, magnesium sulfate and immediate delivery, C4. And you already know the answer just based on these two only you know. C3 is wrong. C3 is deliver. C3 is why wrong? Because C3 is telling you to wait. You will not wait. We are 32 weeks. Then it is option at deliver at 32 weeks. So C3 is wrong. So this is gone. This is gone. So match the column. Whenever it is IUGR, A5. Color Doppler is the most important investigation in management of IUGR. Color Doppler will tell you when to deliver, how to deliver. Please also comment which is the most important USG marker whenever we have got asymmetric IUGR. For asymmetric IUGR, what is the most important parameter what we monitor in the baby? What is the most important ultrasonography marker for asymmetric IUGR? Please comment in the chat box. That means between BPD, femur length, abdominal circumference, which is the most important marker. And how color Doppler? So color Doppler is going to tell me when to deliver. It's a sequential color Doppler, and when it's absent flow, reversal of flow, we are supposed to again do the delivery, otherwise the baby can die. And postdatism. Of course, in postdatism, what happens is that there is a risk of liquor becoming less. So I will monitor the AFI. Of course, NST is a test for fetal well-being, very important, because postdatism, if you with the risk of IUFD, and of course the treatment is I need to induce labor. So D6, and we have our answer, isn't it? A is obviously not 1, A is obviously not 4. So you know the answer A5. That means for IUGR, color Doppler is the investigation of choice. Entire management depends on color Doppler. A5. B2, preterm labor, betamethasone and atosiban, steroid and tocolytic combination. C4, eclampsia, immediate delivery. Delivery is the definitive treatment. Please note this down. Delivery is the definitive treatment. Okay, of course magnesium sulfate will be given. And postdatism, when we cross the due date, risk of liquor becoming less, oligohydramnios. So I need to, of course, induce labor and test for fetal well-being, NSTFI. Now, please also comment in the chat box what things we monitor when the patient is on magnesium sulfate. What is the therapeutic range? Please comment the loading dose of Maxel. What is the loading dose of Maxel? And what is the antidote for magnesium sulfate toxicity? I'm going to give you the answer in the chat box. Please comment in the chat box the antidote for magnesium sulfate toxicity, and please comment the therapeutic range and things we monitor on Maxel, and also comment for IUGR what is the which thing parameter on ultrasonography is very important for measurement. Is this understood? So match the column is a new kind of question. Now again, when this question comes, what happens? Student directly start marking from here 1, 2, 3, 4. No. Please understand this. This is a part of your MCQ only. Your options are starting from here. Are you understanding? So the question is, there are some statements given to you, 1, 2, 3, 4. Which among the following are true regarding hysteroscopy? So this is again a new pattern, and surely this question are coming multiple correct options. That means there can be more than one correct options. We have to see that out of the following regarding hysteroscopy, which are the true statements. Now, please understand this here. The total confusion, students do not know what is hysteroscopy, laparoscopy. So please understand this. One thing has to be very clear. That sir, hysteroscopy is what? Sir, I am going to put in a telescope through the cervix into the uterus, and therefore hysteroscopy is everything to do with the cavity, of the uterus. Okay, so this is basically the inside view. We are going to see what is within the cavity and what is inside. Now, diagnosis of uterine synechiae. Of course, so if it's intrauterine adhesions, also called as what? Asherman syndrome. Please comment in the chat box, why do we get Asherman syndrome? So of course, sir, uterine synechiae or intrauterine synechiae or Asherman syndrome, of course, hysteroscopy can make the diagnosis and also for the treatment. What is the treatment? Yes, sir, we are going to do hysteroscopic adhesiolysis. You can see on the board with the hysteroscopic scissors, we will see I'm cutting the synechiae. Is synechiae gone, cut. So hysteroscopic adhesiolysis can be done. Similarly, sir, if there is any endometrial polyp or a submucosal fibroid, SM, not the outer fibroid, okay? If the fibroid is outside, that hysteroscopy cannot see. So please read correctly. If it's a submucosal fibroid, again hysteroscopy can see. And very important, again a PYQ, if it is a septate uterus, if it is a septum, So septum is projecting into the uterine cavity. So if it's a septate uterus, again we have to go for hysteroscopic septal resection. Laparoscopy has got no role. Is it clear? And what do we do? So we go through the hysteroscopy route and again we make a nick and we cut the septum. Is it clear to all of you like this? See, we keep on cutting and we cut the septum. Is this understood? So all these are the main indications, what I would say, for hysteroscopy for both management and diagnosis also. So now if you see, is it for diagnosis of uterine synechiae? Yes. Is it for management of septate uterus? 100% yes. And management of submucosal fibroid also we can do hysteroscopic myomectomy. What do we do? Because it is within the cavity, hysteroscopic myomectomy is done. Is this understood to all of you? Okay, so 1, 3 and 4. It is not a test for tubal patency. Please understand this. For tubal patency, we do HSG, hysterosalpingography, which is the initial test. And if I want to do the best test, so basically 2 is out. Wherever 2 is there, option that is out. 2 is out, and therefore 1, 3, 4. Isn't it? Thokotali. Clap. Clap if you have learned something new. And why, I will tell you. Please understand this. So 1, 3, 4 is the answer. Sir, hysteroscopy true statements are 1, 3 and 4. Is this clear to all of you? Now please pay attention. Why hysteroscopy is not for tubal patency? Very important. Why? Because sir, in hysteroscopy, when I put in a telescope, I can only see the cornual end of the fallopian tube. Isn't it? I can only see the cornual end because hysteroscopy is only for the cavity. Isn't it? So only the cornual end. Yes. Polyp, fibroid, adhesions, septum, all that, yes. But for our hysteroscopy, when I see, I can only see the cornual end of the fallopian tube and I cannot comment on tubal patency. Why? Because the tube could be blocked over here, which the hysteroscopy cannot see. And therefore, it requires, if at all for tubal patency, laparoscopy. And what is it called? It's the gold standard. Please comment in the chat box what dye is used. What dye is used for tubal patency during laparoscopy? Very important MCQ. And that is the gold standard test. Is it clear? So for tubal patency, my dear student, for tubal patency, either we have got HSG, which is the initial test or a X-ray, and second is the laparoscopy. What we do, please complete the full form. What is it called? Laparoscopy ke baad is one more name. Please comment in the chat box, because laparoscopy and with do which dye we see, and we see the spill of the dye. Okay, so because laparoscopy for tubal patency, the entire, basically the basic is that the tubal patency, I need to see the entire tube. Entire tube has to be seen, then only I can comment on the tubal patency. Sir, hysteroscopy is mainly for the cavity and only the cornual end of the fallopian tube I can see with hysteroscopy. It's like this over here. Okay, all of you look on the board. All of you look on the board. Is this clear to all of you? So sir, when I put in a telescope, yes or no, clap. Nobody will teach you like this. Okay, sir, when I put in the hysteroscopy, sir, only the cornual end can be seen. And I can say whether the cornual end is open. But suppose if the cornual end is open, can I say with confidence that the tube is patent? No. Why? Because the tube could be blocked over here, blocked over here, blocked over here. Tube could be blocked at the ampullary part, ischemic part, femoral end, which I cannot see on hysteroscopy. I require to do a laparoscopy. And what is it called as? Laparoscopy chromopertubation. Yes, laparoscopy chromopertubation. What is the dye? You will comment in the chat box. Is it clear? Now again, very, very important. Arrange in the correct sequence. What is it? So again, when this question comes, don't start panicking. No, very easy. Profuse vaginal bleeding after delivery. So what it is, basically management of PPS. Uterus is flabby. Uterus is flabby means what it is? Atonic PPH. No retained products, no trauma seen. Very good. Initial management bleeding. Arrange in the correct sequence of management. Will I go with balloon, whatever? Okay, so all of you know that whenever it is a tonic PPH, we immediately start massaging the uterus. Of course, for management, tranexamic acid should be given. Do not forget it, very important. Okay, so I'm telling you all extra points, okay, which is not there. Okay, so tranexamic acid is not there, but yes, tranexamic acid should be given. IV tranexamic acid is given for your management, okay, not for tranexamic acid. Yes, of course I will give. Then you start massaging the uterus, and oxytocin is the first drug of choice. Is this understood? So uterine massage and oxytocin infusion, B will come first. So B. Chalo, at least one option is ruled out. A is not first. Okay, so one option rule out. B is the correct sequence first. Okay. B के बाद what do you do? Suppose if it is not responding to oxytocin, then the second line we can go with methergin or methyl ergometrin. Please also comment in the chat box what are the contraindication. Which two conditions I will never give methergin. If the following lady has got PPH, there are two conditions where I will avoid methergin for sure, or methyl ergometrin is contraindicated. Again, it's a very important PYQ. If this also fails, then we go to prostaglandins. Which are the prostaglandins which we give? Yes, sir. We can give PGE1 also, which is mesoprostol, and we give PGF2 alpha also, carboprost. So mesoprost and carboprost. So after the B, we will move to D, prostaglandin. B के बाद D, and you already have your answer. B के बाद A नहीं है, B के बाद C नहीं है. C, already we have the answer. This is all the medical management. If the medical management fails, when the medical management fails, before we go to the surgical management, what comes in between? Yes, sir, the condom tamponade or a balloon tamponade. Okay, the balloon, and what is the name? Bakri balloon, Bakri. लेकिन क्या है वो बकरी नहीं बोलना है, बकरी नहीं बोलना है. Why? It's a foreigner. Okay, so they copied our idea. Our idea was to putting in condom. So they did our idea ka chori, and it is a foreign. So don't say bakri, you say bakri. Bakri. So when you say bakri, this job should slightly drop down. Bakri balloon. And please comment in the chat box a bakri balloon ka capacity. What is the capacity of the bakri balloon tamponade? So balloon tamponade, A will come next. Okay. So medical management, then balloon, and then surgical management. Again, in surgical management, we can try with the ligation of the vessels and B. Lynch suture. Christopher B. Lynch. Okay, B. Lynch. These are uterine compression sutures. They are for atonic PPH to compress the myometrium, and they will prevent a hysterectomy, and they can work. So C, and last option. So B ke baad D, D ke baad A, then we have got B. Lynch compression sutures. Please understand how the sutures are done. Nobody will ask you, but those are like the brace sutures which we put on the uterus. Okay, which we put on the myometrium. Okay, you start from here, go from above, come down, come from behind, come from front again, and we tie a knot over here. Please also comment, this is B. Lynch. Do you know any other? Do you know any other compression sutures also? Please tell the name, comment in the chat box. Very important virgin MCQ. But B. Lynch, and of course the last resort is hysterectomy, E. So if you see, E is last for, okay, last resort is hysterectomy to save the life patient. It's called obstetric hysterectomy. So E is last. So what is the answer? So B is the oxytocin and massage. D is then you proceed to prostaglandins, then you go for balloon, then you go for the compression sutures, and last is the hysterectomy. B, D, A, C, E. This is the correct sequence of events. Very important topic surely coming on. And all these recent advances in management of PPH, already a free video is in the app for all the students. We have already put it, so you can go and check it. Now again, choose multiple. Again, the option is when they come over here question, mistake student walk on, they start marking over here. No, please understand, ध्यान से सुनेंगे, select the correct answer from the code given below. That means your options are starting from here. Clear? Now, indications and prerequisite, they're asking you either it could be an indication or a prerequisite, matlab the criteria for delivery with forceps. Is it clear to all of you? is which of the following. Okay. Now, please understand this. Whenever we are doing a instrumental delivery, please keep this in mind. What are the three main indications? Three main indication is, sir, if it is maternal exhaustion, mother is exhausted, mother is saying, sorry doctor, I cannot push further. Second is if it is fetal distress at full dilatation. Of course, the cervix has to be fully dilated for forceps, fetal distress. And third is if it is prolonged second stage. Prolonged second stage means what? There have been already 2-3 hours and baby is not getting prolonged second stage, or to cut short second stage. Now please comment in the chat box which condition I would want to cut short second stage of labor. It's one very important condition where I want to cut short second stage of labor. Okay, but now two most important, never mark CPD. Many students directly tell me cephalopelvic disproportion as an indication for forceps or vacuum. Wrong. Please understand that there should be no CPD. In fact, when I am applying, that means there is adequate space for the baby to come out. If the baby head is very big and there is no space for the baby to come out, okay, head is big, there is no narrow pelvis, then don't apply the instrument. What is the point of applying the instrument? Is it clear to all of you? Then I will not apply the instrument. Clear? So please understand this, that the pelvis should be adequate. Pelvis should be adequate is a prerequisite. Cervix should be fully dilated, 10 centimeter for forceps. Forceps can be applied either on vertex or mento anterior face. Please tell me what will I do for mento posterior face. Okay, mento posterior face, what do I do? We don't apply. Okay, is it clear to all of you? So delay in the second stage of labor, yes, prolonged second stage. Non-reassuring fetal heart rate, matlab fetal distress, also correct. Vertex, yes. On a head delivery, if it's a head, can I apply forceps? Yes. And mento anterior face, also I can apply forceps. Okay, mainly it is for vertex. Mento anterior face by chance, if we can apply. Mento anterior face, vacuum never. Okay, if it's a face presentation, vacuum is absolutely contraindicated. Why? Because sir, if I apply the vacuum, eyeballs will pop out. Aankh bahar aa jayega. Okay, but the question is about forceps. Okay, so face में vacuum नहीं लगा सकते, but forceps yes, but that also only in mento anterior. Why? Because please tell me what will I do in mento posterior. If it's a mento posterior face, what do we do? Please comment in the chat box. Okay, so pelvis should be adequate, and most important criteria. What about the station? Okay, station is the relationship between the fetal head and the ischial spine. Ischial spine is station 0. Please understand this. In modern day obstetrics, पुराने जमाने में we used to apply forceps at minus station, high forceps, mid cavity forceps at 0. All that is kachra dustbin. Kachra dustbin matlab never to be done. So you will never apply forceps at station -3, -2, -1, 0, even +1. Never. You will never apply forceps at all this station. Station should be at least +2. One of the most important, please keep it on +2, low forceps, and further down +3, +4, +5. Station should be minimum +2, then only I will apply. So यहाँ पे station +1 है, that is wrong. Station +1, can I apply a forceps? Sorry. So third option is out, and you know the answer. Wherever there is third, that is out, and the answer is 1, 2, 4. Clap. Okay. So this is how you answer, or how you eliminate in the exam. Okay, again, if I make this forceps option, if I make it into vacuum, then only 1 and 2, because vacuum mein face mein vacuum is only for vertex. Is it clear? So see how 1 word change. But the question is about forceps. So forceps can be applied mainly on vertex, and by chance if it's mento anterior face, forceps is okay. Vacuum is absolutely contraindicated. Is it clear to all of you? Sorry, station cannot be +1. Station has to be at least +2. Okay, at least +2 station होना चाहिए, then only we will apply a forceps. This is the ACOG criteria. So whenever the station is -3, -2, you will never apply the instrumental delivery. Of course, pelvis has to be adequate, cervix has to be fully dilated, membranes have to be ruptured. Okay, so 1, 2 and 4, 1 okay, 2 okay, 4 okay, 3 is out. Wherever there is 3, 3 is absolutely wrong. 3 is wrong. Station cannot be +1. Moving on to the next question. Again, when the question comes clean bold, because students don't know the meaning only. What is this combined prenatal screening test? Okay, so for trisomy 21, at least when you read the option, you'll get some idea. Now, what is the meaning of combined testing? Okay, so all this dual marker, triple marker, many students have a confusion. Okay, so combined testing means, combined means we are going to do some blood work, maternal serum pe. What test will I do? And along with it, ultrasonography. So blood test and ultrasonography combined is called as combined screening trisomy 21 ka screening test, antenatally or prenatally. Is it clear? And specifically now read the question ka second part. The question is which is in the first trimester. That is the most important. So every word, the important word, it has to be a combined testing. Combined means what? Now you know the meaning. It has to be in the first trimester. Baat samajh mein aa gaya? Yes. So now what is the test which we do? Yes, sir. Dual marker test. When do we do it? It is done between 11 to 13 weeks of gestation. Please also comment in the chat box. There are certain tests which are in the second trimester. The triple marker test and quadruple marker test. They are done at what weeks of gestation? Please comment in the chat box. So dual marker test mein, sir, we do HCG and PAP-A. PAPPA, HCG and PAP-A, pregnancy associated plasma protein A. Is understood to all of you? Please comment in the chat box. What happens to the values? HCG values will happen what? Will it become increase or decrease? PAP-A, you don't have to remember the exact value, but we have to know whether it is arrow up or arrow down. PAP-A, arrow up or arrow down. Okay. So dual marker test is only two components done between 11 to 13 weeks. Most important, sir, it's a blood test. How is the dual marker test performed? Many students do not know this. It's a simple test done on maternal serum. It is a blood test. Maternal serum pe karte hain. Please comment what happens to HCG and PAP-A. Value increase, decrease. And second, we also do the NT scan. NT scan is nuchal translucency, also done at 11 to 13 weeks. So that is also in the first trimester. Is it clear? Up to what is the NT? Sir, every baby at the nape of the neck. If the baby is like this, okay, images we have shown in our lectures also. Okay, so the baby is like this at the nape of the neck, the baby has got some translucent space and we have to measure them. And nowadays we also see whether nasal bone is present or not, because absent nasal bone is also a marker for Down syndrome. So we also call it nowadays, this NT scan has gone one level higher and we call it as NB-NT scan, nasal bone and nuchal translucency. Please comment if NT is how much. If NT is more, if the increase in nuchal translucency is suggestive of Down syndrome, if NT is more. Okay, so now we go at the question and we know, yes sir, HCG is done, PAP-A is done, and NT measurement is also done. Alpha fetoprotein, MSAFP is maternal serum alpha fetoprotein. MSAFP, maternal serum alpha fetoprotein, is a part of triple marker and quadruple marker test, which is done in the second trimester, and that is out because question is about the first trimester. So number 2 out है, जहां पे भी 2 है वो out हो जाएगा, and 1, 3 and 4. 1, 3 and 4. Clap. Super. Is it clear? Thoko tali. Clap if you are getting so much knowledge. Is it clear to all of you? So 1, 3 and 4 is a combined. I repeat, what is the meaning of combined testing, sir? Combined means, sir, doing the mother blood test and ultrasonography. And what is this ultrasonography? Sir, it is the NT scan. And maternal serum is the dual marker test, what we do in the first trimester. So dual marker test and sonography when we do for diagnosis of, for screening for trisomy 21. The important word is all these are screening tests. Please also comment in the chat box what is the confirmatory test in the whole world. What is the confirmatory test? Please comment in the chat box, and how to do the confirmatory test in the first trimester and second trimester. Please comment. I'll give you the answer over there for sure. Okay, so you're going to comment in the chat box the triple marker test, quadruple marker test, when at what weeks of gestation we do it. It's done in the second trimester, and the confirmatory test is what? I quickly repeat. So dual marker test is HCG and PAP-A, which is done on maternal serum, and NB-NT is a ultrasonography if NT is more. Increase in nuchal translucency is a marker or suggestive for Down syndrome, trisomy 21. Okay, it is suggestive, not confirmed, but if in NT is more, you think of trisomy 21. Okay, and another marker I told you, absent nasal bone. Moving on, again match the column. Hormonal profile of a 35-year-old lady presenting with amenorrhea. Why does she have amenorrhea? Multiple options are given. Now here it is absolutely concept based. Please pay attention. What you are supposed to remember is the master and servant relationship. Okay, pituitary is the master and ovary is the servant. Okay, so pituitary से आता है FSH, and ovary will secrete the eggs, and ovary will secrete estrogen, and eventually after ovulation there is progesterone. Now simple logic. So if the ovary is working normally, the master will also be happy and master will be functioning normally. But common sense, if the ovarian function goes down, if your servant is not working properly, what will happen to the master? The master will shout more loudly, isn't it? Baba, work, 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 isn't it? So because if the servant is not working properly, the master has to keep on shouting, Baba, work, work, work. Master will increase FSH. Okay, so here premature menopause, whether it is a premature menopause or a natural menopause, hormonal profile will be same. Or if another thing they tell you is a ovarian insufficiency. Okay, now why I have used the word premature? Because it's a 35-year-old. Okay, whenever menopause is under 40, whenever the menopause happens less than 40 years of age, it is called as premature ovarian failure. Premature, one more important MCQ. Premature ovarian failure is ovarian failure or menopause before 40 years. So whether it's premature ovarian failure or normal also menopause, if it's a 45-year-old lady, then we call it menopause. The answer will be same. What will happen? Yes, sir. FSH will keep on rising, and then eventually LH will also increase. So whenever the lady has reached menopause, ovarian function completely finished. So when the ovarian function less, FSH high. And when ovarian function completely over, that means ovarian function finish, that is menopause. At that time, the master will shout the highest. So please keep this in mind. FSH is highest in the postmenopausal. So sir, high FSH, eventually high LH also, and of course ovarian function gone. So low estrogen, low progesterone. Is it clear to all of you? Or no progesterone, almost gone. Okay, so D4. So yes, D4, all options are D4, but that's fine, but you come to know. Okay, now what is Sheehan syndrome? Sir, postpartum pituitary necrosis. So sir, if there is pituitary gland has undergone necrosis, obviously FSH completely gone. So master himself is sleeping. Master ही सो रहा है, master ही काम नहीं कर रहा है. So in pituitary necrosis, what will happen in Sheehan syndrome? LH will also be low, FSH will also be low, because it's a hypopituitary gland is gone. So pituitary gland, all signals are gone. So low FSH, low LH, and therefore ovary will not function. So eventually low estrogen, low progesterone. So A1. So A1, two options are gone. Two options are ruled out. ठीक है, अभी A and C में से देखना है. And PCOS, my dear student, we know LH-FSH ratio is altered. LH is on the high, it's a tonically elevated. So sir, in PCOS, we get high LH. Please comment very simple what criteria is we use for diagnosis of PCOS, or the criteria we use. LH is on the higher side, FSH could be normal, high estrogen and low progesterone. Why low progesterone? Because of an ovulation. Sir, PCOS patients, there is an ovulation. So what will happen? Sir, only if the female ovulates, ovulation, corpus luteum, progesterone. Only if the female ovulates, then a corpus luteum is formed, and then the progesterone enters into the movie. So sir, ovulation, corpus luteum, progesterone. So if I write no in front of everything, it is also true. Okay, sir, no ovulation, no corpus luteum, no progesterone. And no ovulation is nothing but an ovulation. An ovulation में progesterone low or absent. So an ovulation में, because of an ovulation, progesterone is going to be very low. And therefore, can you comment in the chat box what is the long-term complication of PCOS? Please comment in the chat box 2 or 3 long-term complication of PCOS. Okay, because of chronic an ovulation and chronic progesterone deficiency and high estrogen. So C3, and you have the answer. C is not 2. C is not 2. Okay. And Asherman syndrome, I just now told you, sir, Asherman syndrome is what? Sir, Asherman syndrome is intrauterine synechiae. So, sir, it's a problem with the uterus. But, sir, master pituitary will also be normal and ovarian function is also normal, isn't it? So, sir, in Asherman syndrome, all are normal. B2, utna bhi aapko pata hai, you know the answer. B2 is only with this. B is not 3, B is not 3, B is not 1. B2 is there, and therefore this is the answer. Even if you know this one, Asherman syndrome, all are normal. B2 you can get. So match the column, you can very quickly get. If even if you know 1 or 2 things correct, you can get it correct. Okay, so B2. Okay, B2 hai, and therefore this becomes the answer. A1, yes, Sheehan syndrome, everything low. B2, all normal. PCOS mein option 3, and D4 I have explained to you. Is it clear to all of you? So please keep this point in mind. Next, moving on, again very important drugs and their uses or function. Carbetocin, ये क्या है बे? Carbetocin क्या है? Yes. Sir, oxytocin, the problem is that oxytocin requires a proper cold chain to be maintained. And if the proper refrigerator facilities are not available, oxytocin will not work. And therefore, I have got a newer drug, carbetocin. It is for prevention. All these latest guidelines have been added in the app. Okay, the carbetocin is a newer drug. It is the advantage is it is for prevention of PPH. It is mainly used for prevention. Okay, prevention of PPH. It is a room temperature stable or heat stable. Okay, so carbetocin is a room temperature stable oxytocin. 1B. So at least one option gone. Crystal clear to all of you. Atosiban, I already told to you, sir, atosiban is a tocolytic agent. Atosiban. So carbetocin, atosiban are both opposite. Is it clear? Carbetocin has action like oxytocin. It is used for prevention. It is used for prevention of PPH. Atosiban is a oxytocin antagonist. Atosiban is a, so 2A. Okay. 2A. So this is out. 2 options gone. 2 is definitely not D. Yes, 2 is not D. So this is out. Is it clear? What is indomethacin? Yes, sir, indomethacin is an NSAID, but it is used in medical management of polyhydramnios. Very important MCQ. 3D. And you have the answer already. Okay. You have the answer already. 3 is not C. Okay, so indomethacin is for medical management of polyhydramnios. Sir, indomethacin acts on fetal kidney, decreases the fetal urine production, and therefore indomethacin can be used in management of polyhydramnios, specifically before 34 weeks. Please comment in the chat box what is the problem if I give indomethacin after 34 weeks. Very simple MCQ. Sir, what complication can happen if indomethacin is given after 34 weeks? What is the complication? Please comment in the chat box. Are you getting my point? So indomethacin can be used if the patient is 32-33 weeks. Misoprostol, my dear student, I can use it for MTP also in the first trimester and second trimester. I can also use it for induction of labor. Misoprostol is PGE1. Okay, and also for PPH I told you. So 4C, and you have the answer. And carboprost is PGF2 alpha, contraindicated, absolutely contraindicated, because carboprost is PGF2 alpha. Carboprost is contraindicated in bronchial asthma. Very important PYQ. It has come in Pharmac MCQ also. Carboprost is for PPH management. Carboprost is 5E. Okay, so we have the answer. I'll again just rechecking everything. 1B is there. Yes sir, carbetocin is room table temperature. So यहाँ पे this second is out. Atosiban is a tocolytic. So 2A है, 2D है. So this is gone, this is gone. So 1B, 2A, but 3 is indomethacin, 3 is D. 3 is not C. 3 is not induction of labor and MTP. So this is also out. 3D. What is 3D? Sir, indomethacin is for polyhydramnios. Before, and we can use it at 28, 30, 32 weeks when the mother is having severe breathing problem. Okay, severe polyhydramnios. Okay, so 3D. 4C is misoprostol is PGE1. I can use it for induction of labor and MTP. And carboprost, absolutely contraindicated in bronchial asthma. Clap if you learned something new. And thoko tali. Okay, is it understood to all of you? Now, again, a very important MCQ. Arrange the AMTSL in sequence. Now, there's a recent advances on this topic. Please pay attention. But this is exactly a PYQ and very likely to be repeated. So now, if the question comes, the answer will be slightly different. I'm going to explain to you. Please pay careful attention. But this was the option, and therefore the exactly same options we have kept. I have to arrange in the sequence. Is it clear to all of you? Now, what is AMTSL? Please pay attention. Where AMTSL, first of all, is for prevention. It is active management third stage labor for prevention of postpartum hemorrhage. What it is that, sir, whenever I want to prevent PPH, what is the most important thing? Sir, a uterotonic agent, and again oxytocin is the drug of choice. Oxytocin is a drug of choice, and 10 units. Please keep this in mind. So the dose is also important. 10 units IM or IV. Okay, oxytocin 10 units. But now please understand this. Okay, sir, if there is, please keep this in mind. If there are twins, okay, sir, if there are twin pregnancy, and if only one baby is delivered, and one baby is still inside, and if I give 10 units oxytocin, because 10 units I want both upper lower segment to contract together. So both upper and lower segment will contract together. What will happen if the baby is inside and I give 10 units oxytocin? Yes, disaster, calamity. Why? You have to go to jail. Because, sir, the second baby, fetal distress, because strong uterine contraction, upper lower segment will contract together, rise in intrauterine pressure. There could be also risk of rupture uterus, mother dead, baby dead, fetal distress, baby can die. And therefore always remember that I need to check for twin pregnancy. That means I have to make sure that there are no more babies left inside the uterus, and therefore always we have to check for twin pregnancy, and in twin after both babies. Only after delivery of both babies. Is it clear? If it's one baby, obviously after delivery of that baby. If it's twins, both babies, triplets, all three babies. So after both babies ka delivery. Okay, if it is a twin, it's not that it is a contraindication. Check for twin pregnancy. Suppose it is twins, then after both babies delivery, we have to after the delivery of both babies, I will then give oxytocin. Is this understood to all of you? So please keep this in mind that, sir, I will check for twin pregnancy, which is always the first thing. Why? Because I told if it's twins, there can be a calamity. So A. Chalo, at least एक rule out हो गया. And then after checking for twins, what do we do? Yes, sir. This is then followed by 10 units oxytocin, isn't it? So, sir, let both the babies get delivered. Let both the babies do delivery if twins. Okay. So, check for twins. Okay, we check for twins, and after twins we go for 10 units oxytocin. So A is followed by C, A is followed by C, and we already have the answer. This is then followed by control contraction. I'm giving you one more name. What is it called as? Brand-Andrews maneuver. Okay, control contraction is Brand-Andrews. Okay, one hand is on the abdomen going upwards, and other hand, say you do control contraction, Brand-Andrews maneuver to deliver. The control contraction is to deliver the placenta, for placental delivery. And only after placental delivery, after the delivery of the placenta, after placental delivery, we will then do the uterine massage. So the answer is A. It is not A, B and C. Sorry, it is not A and D. It is A. A is you check for twins or rule out twins. There are no more babies left inside. Then you have to go for 10 units oxytocin. So it is A, C, then B and D. Uterine massage is after placental delivery. Now please understand this, as I have told you, this is a PYQ. This is a PYQ. So please understand this, that therefore I have kept the same options. Okay, I have kept the same option. Now, recent advances. Okay, one more very important point. Anybody early cord clamping or delayed cord clamping? Yes, always remember we prefer to do delayed cord clamping, except when. Please comment in the chat box. Please comment in the chat box which is one most important indication for immediate cord clamping or early cord clamping. So always prefer delayed cord clamping. That's not in the option over here. If it's there, then you have to put that also. Okay, so delayed cord clamping has to be done, which is very important. Okay, cord pulsation stop or at least 2 minutes. Delayed cord clamping is to be done. Please comment in the chat box when do we do early cord clamping. Now, what are the recent advances? Absolutely new. Please pay attention. The recent advances is that in cases where a IV oxytocin has been given, okay, and oxytocin has been given IV specifically, okay, and IV is preferred. IM can also be given. Okay, it's IM or IV. Oxytocin is just, I'll write over here, the latest guidelines is oxytocin is IM, control contraction to deliver the placenta, oxytocin IM or IV. If IV line access is there, IV is preferred. If not, IM. Okay, so 10 units oxytocin IM. Recent advances, IV is preferred. Now, what is the latest recent advances? Clap if you feel happy. Okay, sir, where a uterotonic agent IV has been given oxytocin, then the massage, sustained massage not required. Sustained massage not required, and therefore this is out. But yes, don't worry. Of course, if the option comes and I have to arrange it, then uterine massage will be last. If they don't want to give uterine massage, because the latest guideline says that uterine massage is now not recommended, part of AMTSL, we only go for oxytocin IV or IM followed by your delayed cord clamping and then control contraction to deliver the placenta. Then those three becomes the option. Okay. You will do delayed cord clamping and then you will of course do control contraction or Brand-Andrews maneuver to deliver the placenta. Uterine massage is now not recommended specifically. It's not recommended. It's not that it cannot be done. Sustained uterine massage, that the guidelines clearly mention that sustained massage, okay, sustained uterine massage or prolonged uterine massage not recommended or not required specifically where IV oxytocin has been given. So it's a very important recent advances, and my dear student, all these recent advances video has already been added in our app with all the new guidelines. Surely 1 to 2 MCQs on this recent advances in PPH is going to come along with all the new criteria of the labor active guideline and your recently added MCQs and WHO labor care guide. All they have been added in the app. And my dear students, this look at this beautiful completely colored notes. Every student has told me that sir, once we have seen your videos, we can revise the notes entirely in 2 hours. That's my guarantee. And please, it's going to be absolutely your career changing moment just in 699. If this 35-40 minute video has benefited you, this is a RR course. It's completely recorded freshly with all the recent advances Okay, it is a MCQ based RR, and if with your whichever source OBG you have studied from, don't worry, this is a completely MCQ based RR. And as I told you, 20 to 22 MCQs are going to come in OBGY. If with your current knowledge you are stuck up at 10, 11, 12, after this you're just give 2 days, you can revise the entire OBGY, revise and master the entire OBGY just in 2 days time. Okay, 699 rupees, all the IBQs, all the PYQs of NEET PG FM and your INI CET also, along with virgin MCQs, which is my specialty. If with your current knowledge you are 10, 11, 12, 13, 14 also, after just giving 2 days, your score in OBGY is going to jump up to 20. Okay, 18, 19, 20, 6 marks more, 24 marks more, 6 to 7 MCQs, 24, 28 marks is the difference between rank of 440,000, my dear student. So tremendous score is going to get boosted up just by attending, just by seeing this 2 days videos, and you can finish off in 2 days time. Of course, the course is valid till the date of your exam. So these are recorded lectures. You can see anytime. You can keep on seeing again. What all you'll get, you will get the quizzes and MCQ discussion videos exactly like this. You'll get all the MCQs, important theoretical concepts are also covered, and of course doubt solving, mentorship, and all the recent advanced videos are there. So please enroll in this, and it's absolutely 699, and it is a 75-day validity. So it is going to be valid till the date of your NEET PG examination. Don't worry about that, and you can revise the entire OBGY just in 2 days time. So please make maximum use of it and quickly enroll in this and get in touch with me on phone and WhatsApp on this number. All this is for you to read, my dear student. Each and every question I could know, because I could answer OBGY like a cakewalk, sir. All when I was done, everything, all 22 questions were from the sir's videos and notes. You can say, sir, all questions, it just took 2 hours to revise and everything. Sir, OBGY, absolutely, I have got a rank of 400 in this. All your MCQ video discussion helped me a lot. I could answer everything thanks to the sir video. Okay, so got all correct in OBGY. So same thing will happen with you, my dear student. When you walk out of the NEET PG examination, you will message me and call me, yes sir, all 20 questions were from your lectures. And just this rapid revision course is tremendously going to boost up your score in OBGY, is my guarantee. It will become your most scoring subject, most favorite subject. Please share this video with all your friends and colleagues, and hit the hype button also, hit the like, the subscribe button also, follow on Insta. Lots of important information coming out, and the PDF of this will be also be uploaded on the Telegram. So I was wishing you all the best. So I hope you like this new kind of pattern, which is match the column and arrange in correct sequence, and your multiple correct options could be there. So these are very important questions, and many questions of this pattern are going to come in the upcoming NEET PG examination. Here's wishing you best of luck for the exams.